Welcome to another Six Patterns video. My name is Max.
I'm Kevin.
And we have entered the sixth topic here in our 25 top pearls of pulmonary pathology. And the sixth topic really is sort of the six key, most important pearls of interstitial lung disease, talking about interstitial lung disease and their mimics. And so we've got six of these for you. And the bonus. Don't forget the bonus.
And the bonus.
So this case, the clinical history on this case, this is a 51-year-old female. She presents with cough, sore throat, and blood-tinged sputum over the past few weeks. And she has enough respiratory impairment, she ends up having a wedge biopsy.
Wow. And her infiltrates are probably ground glass with vague nodularity bilaterally. So it's a classic sort of ILD.
And this case was evaluated on the outside, and the outside pathologist noted these blue dots are courtesy of the outside pathologist.
Yeah.
And you can see that we have some organizing thromboemboli within the vessels. And the vessel wall is crazy, right? It's got this crazy
thick
spindle cell thickening. And so that was noted, and I think there's another one over here actually.
Yeah.
Right here, another. So multiple thromboemboli, this medial thickening of the artery. And then also noted on this case was the presence of these polyps of organizing pneumonia. And so this case actually came into us with a consultation question that said, is there some sort of relationship between the organizing pneumonia and the thromboemboli in the vessels? Is this just cryptogenic organizing pneumonia? I mean, recognize the polyps of OP, but what's going on with this case?
Right. So there's a lot more here. I mean, it was interesting that the process is so localized.
Oh, you want to go back to low power?
Yeah, because we got a lot of hemorrhage here. And, you know, everyone loves a good hemorrhage.
But most hemorrhage is artifact.
Exactly.
I mean, this is a very common finding.
Right. Fresh blood in the biopsy can happen from so many reasons. But in this case, beyond the blood, there's also these blue localized areas. It's probably one area cut up in three slices.
There's a nodule, here's another nodule, here's another nodule.
Right.
Probably all from the same area, exactly.
Yeah. So we've got to figure out what the nodule is first. We've got to figure out, it's got a little organizing pneumonia in it. So nodular organizing pneumonia. We need to see if there are any other features in here that can help guide us in a path towards a correct diagnosis.
Exactly. So if we go to higher power here, we see right next to this polyp of organizing pneumonia a whole bunch of fibrin.
Yeah.
Right? And fibrin tells you that there's injury occurring at the time of the biopsy.
Right.
And organizing pneumonia tells you that there was injury occurring 7 to 10 days prior to the biopsy.
So we have acute and organizing injury.
Exactly. Which tells me injury is happening repetitively over time.
Good point.
In this area.
Yeah.
Now, there's something unique about this fibrin here, I think, because oftentimes you will encounter fibrin in a setting of acute lung injury, and it's just pure fibrin sitting in the airspace. This fibrin is sprinkled with red blood cells.
Yeah.
So what does the presence of red blood cells tell you when it's embedded throughout the fibrin like this?
Well, I think it's telling us that this fibrin is occurring in a setting where there's also vascular injury.
There's already red cells in the airspace when the fibrin is being formed, right?
Yep.
Which tells me there had to be bleeding first, and then the fibrin forms. So when I see red blood cells all trapped up in the fibrin like this, not just one or two, but like a bunch trapped in fibrin like this.
It's a key.
And then I see this much hemorrhage out here, I start thinking, maybe this is not artifactual hemorrhage, and maybe this is true hemorrhage.
Right, so it's the association with a more specific finding, meaning the blood in the fibrin, and the character of that fibrin can also help us link these two together. And what do we see in that fibrin? Let's go look at some of that at higher magnification. So the funny thing is, fibrin is a pink thing for me. This one doesn't look all that pink. It's red, where there's fresh blood, but it's also kind of brown where it should be pink.
Yeah, it has a little bit of a brownish hue to it.
Yeah.
And that's because of cells like this.
Siderophage.
Yeah, hemosiderin-laden macrophages.
Yeah.
So I don't know about you, but now I'm starting to get quite concerned about this case, because in this particular case, we've got fresh red blood cells in the air spaces, and we've got hemosiderin-laden macrophages, and we've got acute lung injury with fibrin and some organization.
Wow.
So what do those things tell you already?
Well, they're frightening to us because we know the consequence of this. If we are correct in our hypothesis, this person has a pulmonary hemorrhage syndrome.
Precisely.
Then they're at risk for sudden death. And most people don't realize it. But if you get this case on a Friday afternoon and you start thinking this is a diffuse alveolar hemorrhage, you have a responsibility as a pathologist. This is one of the few medical emergencies in pulmonary pathology. You have to call somebody. And if you can't reach the doc because the office is closed, you got to call the hospital. Because for sure, if you're right, this patient is in the hospital, right? They just had a lung biopsy.
Right.
And you're going to call the nursing station, and you're going to say who you are, and you're going to say, I need to talk to the nurse taking care of Mr. Jones or Mrs. Suarez.
Exactly. Because I'm worried this patient has an acute and organizing alveolar hemorrhage syndrome, and these patients can get very sick very fast.
They can have a fatal exsanguination by hemoptysis. And one of the triggers, one of the keys for that is looking for a specific feature that occurs in this setting that is even a worse harbinger. And what's that, Max?
That is the presence of capillaritis.
Capillaritis, the dreaded capillaritis.
And in this particular case, we have tremendous capillaritis.
It's subtle, though, isn't it? I mean, you could miss that.
Oh,
I mean, if you weren't keyed
capillaritis
into
is
it.
always subtle,
Yeah.
right? This neutrophilic infiltrate that's within the interstitium, it's actually within the capillaries within the interstitium. Look at how this interstitium, I can't see any capillary network here at all. Because just like if you're a renal pathologist and you know endocapillary proliferation within the glomeruli, it's the same pathology occurring here. We've got endocapillary proliferation occurring in the interstitium.
The neutrophils are in a line and they're obscuring the capillary.
They're obscuring the capillary. And what's going on there? Complement is being activated and they're destroying the basement membrane of that capillary network. And as soon as that happens, you get fibrin and you get the red cells out within the
and then you get
here.
hemoptysis.
Exactly. So this is indeed a case of acute and organizing diffuse alveolar hemorrhage with capillaritis.
On the phone.
So it's a phone call, and it's at least at the bare minimum, you have to say if ANCA studies have not already been done and more broad spectrum serologic studies, they should be done in this
Get those going. And what they'll do typically in the intensive care unit for a patient like this, if they don't have them on steroid, they'll put them on steroid. And they don't give them oral steroid, they give them intravenous steroid.
High dose intravenous steroid.
They may make a different choice tomorrow morning. They may take them to plasmapheresis tonight. It just depends on the different practices. But something will be done based on your call. So don't think it's a waste of time. And if you're unsure, if you don't see the capillaritis, you can still call and say, I'm concerned this might be a hemorrhage syndrome. Maybe you don't get super excited, but even then they'll put them on steroid that night and see how things sort out in the morning.
And order the serologic studies, which are essential for the clinical pathologic diagnosis in this case.
Yep.
So the pearl in this, most blood is artifact. But if you see blood in association with the features we talked about, acute lung injury, evidence of hemorrhage, hemosiderin-laden macrophages, and capillaritis, that is one of the few pulmonary pathology emergencies. And
Diffuse
you just pick up the phone.
Alveolar hemorrhage
and
with
make a phone call.
Great. We covered it.
All right. That's it for this case. Don't forget to like and comment below. You can hit the subscribe button if you like. And hope you enjoyed it.
Thanks a lot.